Hello everyone, thank you for joining us for National Primary Care Week. Today is our last day and we are joined by Dr. Brita for a conversation on primary care and underserved populations. I hope you all are ready for an interactive presentation. If at any point you would like to contribute or you have a question, feel free to use the chat box or the Q&A box. Both of us can see it, so one of us will bring it up. Dr. Roy is a clinician investigator researching ways to reduce health disparities by identifying and promoting positive psychosocial factors at the individual and community levels. She is investigating mechanisms by which positive psychology can prevent disease, as well as developing an actionable framework to measure and promote the health and well-being of entire communities. In addition to her research, Dr. Roy also enjoys teaching health profession students and internal medicine residents in the classroom and while taking care of a diverse array of patients on the hospital floors. Dr. Roy pursued bachelor's and master's degrees in biomedical engineering at Vanderbilt University and Wayne State University, respectively. She then went on to the University of Michigan to pursue a combined MD and PH in health behavior and health education. Dr. Roy subsequently completed residency training in internal medicine and served as chief medical resident at the University of Alabama at Birmingham prior to completing the Robert Wood Johnson Clinical Scholars Program at Yale University. So I present to you Dr. Roy.
Hello, everyone. If you have trouble hearing me, just let me know through the chat. And thank you, Malika, for the very kind introduction. I'm really excited to be here today on National Primary Care Week. As Shelly mentioned, I'm Director of Population Health at Yale Medicine, which is our faculty practice at Yale. So I think a lot about how we deliver primary care and how we can best serve our underserved populations, as many academic medical sectors are in. So I do hope to make this webinar highly interactive and would love everyone to participate using the chat box as we go along. I'll be posting some questions to think about. So just go ahead and type in anything that you're thinking. There's no right or wrong answer, but the more you all contribute, the more fun and interesting this webinar will be, and the more everyone will be able to learn. I do, want to state up front that we are going to be talking about things that may be, slightly uncomfortable, or, just things about like racism, sexism, biases, and those are the types of things I think are important to address when we're talking about underserved populations. So don't be afraid to also throw those things out there. All right, so the first question is, what impacts health? And so for this, I have a visual for everyone to look at and think about. This visual is kind of a cartoon illustration of a typical city, and likely an underserved, a healthcare underserved area. And so I look for everyone to look around this diagram and type into the chat box what you observe that impacts health. All right, I see clinic pop up in the chat box. Certainly health and health care is going to have an impact on health and health outcomes. Environment, education, crime, food, transportation, housing, stress from social interactions. Great. Liquor store, housing, food, religion, community, violence, socioeconomic status, transportation, okay, so many of you have mentioned both clinical factors, but also non-clinical and community or social factors that have an impact on health, which is Fantastic. That's exactly what we're going to be talking about today, and what primary care physicians think about when caring for their patients and thinking about what impacts their health outcomes. Next, I want to challenge you to keep looking at this diagram and think about things that you do not see in the visual that impact health. Family dynamics. Great, so that has, we can see a family, but it doesn't actually state anything about family dynamics, and that certainly has a key role in health all the way from birth to adulthood. Genetics, environmental changes, which we can't see, and mental health, that's great. Perceptions about the healthcare system, which may vary from one place to another and may vary between cultures. Access to healthcare is another great one. We see the clinic, but we don't know who can actually get care there. If you don't have insurance, or maybe if you have Medicaid, they might not access that. The availability of healthcare as well. All right, these are all outstanding responses. We're going to come back to this, but it sounds like many of you already have some grounding as far as the social determinants of health, which again, I say that we're going to be increasingly aware of as we go through this presentation. So next, I'm going to point you toward the center of the diagram where you see a young man being put into an ambulance. And his name is Rayshawn. We're going to talk about Rayshawn and his clinical experience of asthma, and as a primary care doctor, thinking about all of the different environmental contexts and family contexts that also influence his asthma and control of asthma. So this is kind of a text-heavy slide just to give you some background about Rayshawn. So I'm just going to read it out loud so that all of us can follow along together. So Rayshawn is an 11-year-old African-American boy who you've been seeing in your primary care office since he was born. He experienced difficulty breathing during gym class at school, and he's had prior hospitalizations due to his asthma. So because he had this recent exacerbation at school, he is coming in to see you. After some discussion with him and his mother, you realize that his housing development has ongoing problems with roaches and rodents. He walks to school near a major highway. His mother is a single mother. She smokes and she works 2 jobs. They don't have insurance, but he and his siblings at least are covered by Medicaid, thanks to CHIP. He has limited access to clinics that are an easy traveling distance that also accept Medicaid and or are still open after school and after his mother gets out of work. Rayshawn's father lost his job and disappeared, and then was found to be recently arrested for drug abuse. His mom's stress level is high because she's really concerned about her son's health and being able to provide for all of her children. And his grandmother lives with a family, and so she really helps out in the home, cooking meals and helping the kids with homework while his mother works. So this is kind of Rayshawn's context, as a young kid living with asthma. And I want you to keep his story in the back of your mind as we talk through the rest of this. And we're going to come back to his story at the end. I guess before we move forward, why don't we quickly think about what specific things in his story do you think are exacerbating his asthma? How could we perhaps help him get better control of his asthma? Let's just take about 30 seconds, type into the chat box ideas you have about things that are impacting Rayshawn's asthma. Awesome. So his mother smokes. He doesn't have great access to health care, medication, housing location, and parental addictions, and where he lives has problems with roaches and rodents that certainly could have an impact on his asthma control. Great. All right, we're going to stop there and move forward. So as a primary care doctor, we can certainly prescribe medications, rescue inhalers, but someone mentioned perhaps lack of access to medication, which could be, even if we prescribe it, we don't know if he and his family can afford those medications. We can help him and his mother and the school even coordinate on developing an asthma action plan. And that's a plan as far as what to do when there's an exacerbation, but also a plan to help to prevent exacerbation. We could maybe prescribe some additional preventive medication. And we could counsel on the importance of exposure reduction. Anything else we might be able to do? Again, just type into the chat box. I mentioned work with the school nurses to get medications and involve social work if available. So we might want to involve social work perhaps to help get rid of like the exposure to roaches and rodents. They might be able to facilitate that. Immunizations also will be very important given his asthma history, especially for things like pneumonia and pertussis. And if we see her mom, we can also counsel her on stopping smoking. That's a really huge intervention that we might be able to have. Great. So you guys talked about that. One other thing that will be challenging is the fact that they do live near a highway. So someone mentioned the social worker, or someone else just mentioned public officials. And so those are people that we can certainly work with to talk about kind of broader context policies that may be able to reduce air pollution that would help our patient and many other patients in the area that are likely suffering from asthma. Great. And then one other thing to think about is his and his family's levels of chronic stress or toxic stress really that can also be exacerbating asthma. All right. So I wanted to introduce the concept of population health, which is an increasingly popular term and certainly a related concept in this area. So population health is the health outcomes of a group of individuals, and that includes the distribution of outcomes among that group. And it's important to think about distribution because that helps us understand if our outcomes are equitable across the population or not. So why is it important to think of patients in populations? Any ideas in the chat box? Why should we think of patients in populations? Different populations are affected in various ways. Yep. And why is that? Why are they affected in different ways? Great. So environments, cultures, habits, genetic predispositions, and then also just different exposures depending on where they live. So that's exactly it. The reason is that patients live within a context. And so by thinking about patients as populations, we can have a better sense of what those different contexts are and tailor accordingly. In medicine, the traditional way that we have thought about patients is always an individual patient in front of us, but we always have to keep in mind that that individual is embedded within a family, and then a larger neighborhood or a community, and then of course society. And so understanding those different components is really helpful when we think about patients and populations. So what are different ways we might actually group patients? What might these different populations be? Someone said race, gender, age, zip code, disease status, location, socioeconomic status, sexual orientation, neighborhood, religion, race, ethnicity, gender, sex, and ability or disability. And so that's exactly right. And you guys hit on many of the key ways that we can group patients. Usually it's either demographic or geopolitical, or on the clinical side, we often group patients by specific disease status, like if they have diabetes or high blood pressure. But health systems also think about the patients that are the highest utilizers of the emergency department and hospital, the patients that are the highest cost, especially as we move more towards value-based payment systems. We might also think about insurance enrollment, whether or not patients have insurance or what type of insurance they have, which might modify the types of interventions we are able to provide for certain groups. So the key here is that each person belongs to many groups, and a single person who is, let's say white, MSM, lives in Harlem and has Medicaid, also has diabetes and heart failure. And so there's a certain kind of clinical context, and based on their geopolitical and demographics, we know that they have certain risk factors. But if we slightly modify the situation, and so it's still a patient with diabetes and heart failure, but now is from Manhattan and has Blue Cross insurance, it's a very different set of risk factors and exposures that they may have had in their community environment. So this just, I guess, brings up the point that where you live does matter. And so I'm going to show several slides that demonstrate the impact of the place that you live and why it matters for health. And as we go through, feel free to type into the chat box if there's information that surprises you, and if so, why. And then information that might not surprise you, and why. And finally, why it's important to be aware of this type of information. So this is just kind of a summary slide stating your zip code can be more important than your genetic code, and there are profound health disparities depending on where you live. This shows the underlying causes of death in the United States in 2000. And these are preventable death rates by state. So on the left side of your screen, you can see the age-adjusted preventable death rates. And the dark red is where there's the highest rates of death. And that kind of lighter peach color is the lowest rates. And then if you look to the right, where it has obesity and diabetes by county, there's pretty good overlap between those and the preventable death rates by state graphs. If we look at the number of deaths, we can see that the vast majority are caused by obesity, inactivity, and smoking. So health behaviors that are modifiable. In 2014, more than 1 in every 3 American adults had obesity, and these rates have been rising. But we've also found that the prevalence of obesity differs by other factors, including race and ethnicity. So this is a similar map to the obesity map we saw before, but now there's 3 different maps. We're all the way on the left, we're seeing the rates of obesity among non-Hispanic whites. And the dark red in these graphs is the highest percent obesity, and there's almost no red on that non-Hispanic white map. The Hispanic map shows some dark red areas, and then the one on the right for non-Hispanic blacks is showing higher rates of obesity in many areas of the United States. These are maps of King County, Washington, which is where Seattle is. And this is Census Tracts level rates of minority rates, low income, and low educational attainment. The red, again, is kind of the worst, or the highest level of low educational attainment or low income. And again, you can see that these maps kind of mirror each other. So the places of low income, also places of low educational attainment, and generally also places that have lower percentage of white. And the next slide is the same King County, Washington, but then showing the disease rates of obesity, diabetes, tobacco use, again, all overlaid, preventable hospitalizations, adverse childhood events, which are a set of 7 events that may occur during childhood that portend poor health outcomes as adults. And those are things like being exposed to trauma during childhood, either in the home or in the neighborhood, having a parent that was imprisoned, having parents that were divorced, things like that. And then finally, frequent mental distress also kind of overlays here. And this next slide kind of gets to Kelly's point a bit about food. So you can live in a desert but still drown in a swamp. And what this is showing is a map of Los Angeles, where the darker green areas are the highest income, and the light green areas are the lowest income areas. Overlaid on top of that are these yellow squares. The yellow squares represent fast food chains. So you can see that in the lower income areas, there's a lot more fast food restaurants. And in the dark green areas, there are very few or almost no fast food chains there. Often people talk about food deserts, like there's nowhere to get healthy food, but you can reverse that and think about these areas. Not only is there no place to get healthy food, perhaps, they're living amongst many places to get unhealthy foods, which certainly is much easier and cheaper to grab on the go. So I actually love this, diagram that shows in New York City, just 6 subway stops away from each other, 2 neighborhoods have an 11-year difference in life expectancy. So Murray Hill has life expectancy of 85 years, but East Harlem has a life expectancy of only 76 years. So what are some of the reasons you can think of that cause this great difference in life expectancy? Again, just put into the chat box what might create this huge gap in life expectancy. These are sort of pictures of the two different neighborhoods. So we have living in a food desert, not having access to healthy foods or health care, historical racism and housing developments that contributes to segregation, youth violence that can negatively skew the mean. That's great. Youth violence impacts usually men of color, Hispanics, and African Americans below the age of 35. And so losing your life at such a young age certainly is going to reduce the life expectancy of that area. Gentrification is another one. Great. All right. So, oh, that did not work. So other things to think about, sorry, it's not showing up on your slides. We already talked about in Murray Hill, good health outcomes are certainly related to having access to nutritious foods, safe and walkable streets, active playgrounds and public spaces, access to good jobs and employment that may even provide health insurance, educational opportunities and high-quality education, and stable housing. In East Harlem, those residents of that neighborhood don't have those essential elements that Murray Hill does, and they're more likely to be burdened with high rates of crime. People already mentioned violence. Also things like obesity, diabetes, and other chronic illnesses that they have a harder time being able to self-manage because there are often fewer programs available to be able to help manage those conditions, but also often fewer places to even get healthy activity, walkable streets or playgrounds or other areas of like parks and green spaces, and people already mentioned access to healthy foods. You guys are right on. So I wanted to quickly go through this exercise of, what affects health, and we've now moved forward. So it's given the answer away, but 40% of health outcomes are attributed to socioeconomic factors, and 30% are attributed to health behaviors. 20% is clinical care. It is a very important 20%, and as primary care physicians, we certainly focus on the clinical care, but we also do focus on health behaviors and these other kind of broader context factors. Finally, the 10% physical environment, another key 10%, and people have already mentioned how important it is to work with city officials or other policymakers even to modify the local physical environment to make it a healthier place to live. So next I wanted to talk about health disparities, and if we think back to our definition of population health, we can remember that distribution was clearly part of that, and that's because health equity is, plays a key role in population health. So what types of things influence the distribution of health or health equity? So primary care providers certainly have an impact on health equity. Insurance, either not having insurance or Medicaid or a high deductible plan might mean that you don't have access to all levels of health care. Where providers wish to practice, there are certainly areas that are what we call health profession shortage areas, where people don't have access to health care, to physicians. Someone else mentions government and the spread of resources at its systemic level. Great. Community policies can certainly impact equity of health outcomes. Locations of grocery stores. So not only do they need to be there, it depends on where they are, proximity to where someone lives, or the ability to get there with public transportation. Someone else mentioned access to education, especially health education, and knowing when it's time to go to the doctor, and not waiting until things get to the point where they're perhaps untreatable. One related one might be health literacy as well. Someone else mentioned no paid sick leave or maternity leave, which might mean that you might not even be able to have time to get the health care that you need. Great. So one other cause of differential distribution that's kind of been in the thread of what people have mentioned is unequal care by healthcare providers. So in 2002, the Institute of Medicine released this report called Unequal Treatment, which basically just reminded us all that physicians are living in the same society as everyone else. And so we're all kind of subject to certain biases against, it might be race, it might be gender, it might be sexual orientation, it might be obesity. We all harbor some implicit biases. So not that, most physicians are explicitly or overtly biased against certain groups of individuals, but that they may be unaware of these. But forcing yourself to think about it and become aware of these biases can actually allow us to change the way that we treat people and make sure that we treat people more fairly. So previously there have been a number of studies to show that physicians do treat people differently, have different types of conversations with patients based on those various types of biases, but that by being cognizant and aware of those things, that physicians can actually change their own behaviors. One other, or I guess this diagram shows how all of those other causes of health disparities work. And many of you have mentioned these already. Living in disadvantaged and neighborhood environments certainly decreases access to healthy foods. It also may have different food culture, and that's not necessarily all low socioeconomic areas, but just different ethnicities or different genders or different groups may have different views on food and what is normative to eat when. We've talked about green spaces and safe places to walk, prevalence and normalcy of smoking, advertising of smoking and of fast foods may vary by neighborhood, as well as access to health care. And so we know that all of those things have an impact on unhealthy behaviors that certainly portend poor health outcomes. In addition to that, I'll call your attention to the orange kind of pathway. And that's the pathway that follows people sort of across the life course and understanding that exposure to violence at a young age, those adverse childhood events, not having strong social ties and neighborhood supports, as well as feelings of lack of safety and discrimination, lead to long-term chronic or toxic stress, which also has a direct impact on the body to result in poor health outcomes. So sort of these two mechanistic pathways that we believe lead to poor health outcomes. And so as primary care physicians, understanding both of these pathways and trying to work with the patients, but then also work with others in the community to start working upstream to tackle some of these issues can help to keep our patients healthy and living really full, long lives. So if we think back to our patient, Rayshawn, you guys already mentioned many aspects of his story that contributed to this poor control of asthma. So a few additional ones, that I'll highlight here are, you guys already mentioned things in his housing development with roaches and rodents, the fact that he walks to school near that highway, being exposed to the pollution, and someone suggested working with local policymakers to maybe, if you can't move the highway, at least starting to incentivize low-emission vehicles, for example, can improve the air quality. His mother smokes, and we talked about the importance of counseling for smoking cessation. Even if you're a pediatrician, you still have a role in counseling the mother, and you can even prescribe medications or other ways to help her quit smoking. We talked about insurance and healthcare access, both due to insurance, but also due to proximity and availability near public transportation options. His father was arrested for drug abuse, and so that is one of those things that makes the adverse childhood events criteria. So Rayshawn would certainly have an adverse childhood event which could be contributing to his asthma. And we know his mom's stress level is really high, working these two jobs and providing for all of her children, which probably Rayshawn also feels. And so it's important to be aware of that as well. And when we are counseling Rayshawn and his mother in clinic, being aware of those limitations and constraints and really trying to provide solutions that work with her schedule and with the living situation that she's in, and maybe even including the grandmother in those discussions if possible, might be a way to really help Rayshawn, his health status, and potentially the entire family. So as a primary care doctor, I think one of the things I enjoy most about primary care, and I think what most of my colleagues enjoy most, is that we really see the whole patient in the context of their lives. We really try to work with the patient and their family to reduce health risks and to promote health actively. And so part of that, maybe through medications and adherence, certainly is important, but also by reducing risks over the entire life course. As physicians, we are also respected in the community, and so we're able to lead change in the community. We can't do everything ourselves. We can't solve all of these problems in the community, but we can actually work to convene groups, by thinking about who else cares about these issues in our community. And bringing those people together, I like to call it create a coalition of the willing, but by bringing people together that don't usually work together in transportation and city council, in grocery stores, in education, all of these people are contributing to the health of your patients. And so bringing them together to collaborate and communicate And everyone kind of has the same goal of helping people in their community, live well. They want everyone to have high well-being. They want everyone to be productive members of society. And so by helping everyone kind of see that bigger picture and that everyone has a shared goal, you can actually have a big impact in your community. And finally, with that, it is really important to monitor outcomes and monitor impact, both short-term and long-term, to make sure there aren't unintended consequences of a potential intervention that you might adopt in your community. So those are some of kind of the big picture ways. So this, I'm going to bring us sort of back to this diagram, and you may have noticed when you looked at it before, there's this blue river sort of thing that comes through, and these are showing you the different steps to lead sustainable community change. So that first step is taking a step back and seeing the bigger picture of your patient kind of within the community context, and then focusing on the areas that are most important in your community. After that, you want to find others who care about these issues. And it's important for you and everyone who cares to think about what it's actually like, for one of your patients to live on a day-to-day basis. And that's how you can think about not only what's most important, but then how to act on what's most important, and working with those key stakeholders in that area to create change. Communication is super important within your group of stakeholders, but then also with community members and engaging them in the change, and then coming together for action for sustainable change. So those are kind of the main points I wanted to highlight today. Primary care, I think, is in a state of flux. We have a very unique role to play a role individually in our patients' lives, but then also the greater community at large. And I think as healthcare moves forward, primary care will be playing a larger role in these areas. So I'll stay on for a little while longer and happy to take any questions. Please just put them into the chat box. And thanks to everyone for participating. This was really a lot of fun. So one question that's just come up is, what can we do as physicians in training to ensure that we see patients during our training, that we keep seeing the bigger picture and seeing our patients for their whole selves? And that's a really great question, because as you move through your training, especially once you get to your clinical years, there isn't always a lot of focus on the big picture. And the reason is it is also super important during medical training to learn all of that medical information that is also extremely valuable. The way that you can, as a trainee, keep that big picture in mind is by always asking your patients about it. Keep that as part of the conversation and the discussion. And once you get to your third year of medical school or the clinical years, you'll be taught how to take a full patient history. And part of that history is what we call the social history. And sometimes that becomes a checkbox of whether people, of health behaviors, like whether people smoke, if they drink alcohol, if they're using illicit drugs. But that social history should be expanded. And we should be asking patients about their family environment, about their social support, about their education level. All of those things can help you, with every patient, make sure that you're keeping that bigger picture in mind. Another way to also keep that big picture in mind is health literacy. And so even in procedural specialties, again, you'll be taking those histories, but making sure when patients are being asked about shared decision-making, about whether or not they want to undergo a procedure, when getting consent, using language, whether it's the text on the form or not, but using language that the patient understands and making sure that there's a feedback loop, that they are interpreting things the way that you hope that they would will also help you keep that bigger picture in mind. Another question that's popped up is, on advocacy level, is there something students and healthcare professionals can do to improve access to care? The answer is yes, there's always something you can do. It may, of course, be local at either the community level or like the clinic level or the state level. So some of your access to care in your state will depend on whether Medicaid was expanded and what the options are for publicly available insurance plans. You can actually, if your state did not expand Medicaid, certainly that is a key thing you can advocate for at the state level. Also, understanding what the publicly available health insurance plans are and understanding those limitations may help you advocate, again, at the state level for certain policies to be put in place to make sure everyone can afford a plan that actually provides the preventive services and basic healthcare access services they need that won't allow them to go broke. So they won't be super high deductible plans. Locally, you can also work with your clinic or hospital to open up more spots for potentially uninsured patients, to open up free clinics potentially, or clinics that function on more of a sliding scale. So those are some of the basic ways that initially come to mind as to how students certainly can have a role in improving access to care. One more question came up that asks, what are some opportunities students can pursue to learn more about social things that affect medicine, like policy or economics? There are lots of opportunities to be able to learn more about these social determinants of health. Some of them are formal. So, for example, you could pursue another degree like a master's in public health or public policy. Those are kind of more intensive ways to truly learn about social determinants of health, especially if you're interested in research or health economics or ways to influence public health and public policy. There are also other types of fellowship opportunities you can do after residency that can train you more in these areas. So an example is I did the Robert Wood Johnson Foundation Clinical Scholars Program, which is now transitioned to the National Clinician Scholars Program. And so these are 2-year fellowships that you can do after any type of residency to learn more about social determinants and how to have an impact. Otherwise, there are shorter, like summertime courses you can do, or on-the-fly opportunities like the one provided today, just to be able to be more aware of what's available. And finally, I would support going to other meetings, either regional or national meetings. I'm very aware of the Society of General Internal Medicine that provides a lot of both materials, but also workshops about the social determinants and how to influence determinants at the local, like healthcare level, but also larger policy. But family practice and pediatrics also have large national organizations that work on these issues as well. So I encourage you as students even to get involved now. The societies are always looking for trainees that want to be engaged in this type of stuff. So definitely encourage those larger groups. All right, I think we are getting close to the end of time, so we will start wrapping up.
Thank you so much, Dr. Roy, for this insightful presentation. As a future physician, I feel empowered on how to address some of the socio-environmental factors that affect a person's health, and I hope the other participants and other students do as well. Thank you again, everyone, for participating in today's webinar and in National Primary Care Week. We've wrapped up the week, and by next week, we will have all of the webinar recordings and PowerPoint PDFs available on our webpage, so please look out for that. Enjoy the rest of your day and have a good weekend. Thank you.